back. Great. Uh, we're, uh, so the musical communities are often a little more open. So there were friends of the family who were Black, who were Hispanic, Asian, gay, and they were friends of the families. And so that's, again, part of who I was growing up, and that informed a lot of my evolution as an adult. I also was lucky after college to be able to travel. I backpacked on the cheap, but still was able to go to a lot of places that exposed me to cultures that were non-European. And so I really feel like I gained some perspective that a lot of people in our country don't get. And I was very grateful for that. And that definitely shaped me a lot. Professionally, I've been a school social worker. I was a school social worker for 20 years in Jackson Public Schools in Jackson, Michigan. I was a therapist for a little bit longer than that. I also am now Chief Clinical Officer at Midstate, and for years before I came to Midstate, I was an advocate for social justice. So this billboard is a campaign, an initiative that I started called the Real Men's Project, which was focused on prevention of domestic violence and sexual assault by focusing on fathers being role models for healthy relationships. I'm also, as you can probably see from the camera, white. I'm also middle class. I'm straight, and I'm an ally to populations that don't generally have some of the privileges I do as someone who's a beneficiary of white male privilege. I've been an ally pretty much my whole life, but that doesn't diminish the fact that I'm definitely a beneficiary of some of the privileges that unfairly benefit some people in our culture and disempower or do the opposite of privileging for other communities. I'm also, and this may sound random, I'm 6'2" in terms of height. How that's relevant will become apparent shortly. And I'll turn it over to you, Sarah.
All right. Hi, everyone. For those of you who don't know me, I am Sarah Cerna, she, her, hers. I'm a prevention specialist along with Sarah Andriotti and Carrie Golvis with Midstate Health Network. Yeah. And then where I'm from. So I've done a bit of a Midwestern tour in terms of places where I've lived. So that took me from Indianapolis, where I was born, to a suburb of Milwaukee, to Portage, Michigan, where I went to middle and high school, and then Ann Arbor to college, and then Cleveland to grad school, and now I'm back in Lansing. I haven't done a lot of traveling outside the States, but most notably, I've been to Japan. I did a public health study abroad there, which really kind of shaped my current career trajectory. And I have had a mixed bag of professional experiences, both in terms of internships and work before I came to work at Midstate Health Network. Those included justice system social work. So I was at an internship my first year of social work school at the Cuyahoga County Public Defender's Office. And then did some therapy work as a therapist for my third year of my dual degree program there at Case Western at our university's counseling service. And then before I came to Midstate Health Network, I worked at Barry Eaton District Health Department. So I have that local public health expertise as well. And also, I come to this work with a variety of different identities, as so do all of you. On my end, I am white. I'm a straight cisgender female. I am a millennial, very short cutoff, I think about 3 years from becoming Gen Z. So I'm kind of a cuspy young millennial. I am Jewish and I am neurodivergent. And to contrast with Danny's 6'2"ness, I am 5 foot, none inches. And I have 3 photos up here as well, and I'm just gonna go through these quickly. And of course, if any of you have any questions about them later, I can talk about all 3 of these photos for a while. So catch me later if you're interested. But that first photo, that is Hikone Castle. That was in the town where I studied abroad in Japan for 5 weeks. And it was a public health themed study abroad. And that was where I really first began to consider my like career trajectory in public health as something that was plausible. And also in Japan, that's where I really started to have conversations about how stigma is so cultural and how one community approaches stigma to behavioral health is completely different from how another community may approach it. And that's how we need to be thinking about how we are reaching those communities. If we go down to that middle photo there, that is Steiner House. And that house is over 100 years old. That is where I lived in grad school. And the special thing about Steiner House is that it is a co-op where no 4 people from any one country could live there at the same time. And I was one of the very few native English speakers, one of the very few white people living in that house. And then that last photo, that's of the Cuyahoga County Jail, where I did a lot of my work that first year of social work school. And I don't know if we have anyone in here who listens to Serial, the podcast. That jail, season 3. So that is where I really started to think about and realize and acknowledge how that jail and jails like it and prisons like it, those are some of the worst outcomes for the that's kind of like the end point of where things have really, really gone wrong with the systems that we have. And it is very obvious when you go into Cuyahoga County Jail or other jails like it, especially in places like Cleveland, that systems have failed because of historical racism, classism, et cetera, and other forms of bigotry and hatred. All right, Danny.
Thanks, Sarah. And I'll just share that I had a summer internship when I was in college in New York, working at Brooklyn House of Detention, and it was only, I don't know, 2-3 months that I worked there. But you're right; it really, if you have any involvement in the legal system, and you see who is incarcerated and the disadvantages they've faced, it's a stark experience of systemic inequities. So I always feel like it's important to start really focusing any presentation, any discussion on why are we talking about this? Why does it matter? Why is it relevant? So this is the overdose death rates in the last year that we have data for in our region. If you look here in the pink, the white overdose death rate per 100,000 is 20.8. It's more than twice that for African Americans at 50.7, and it's even higher for Native Americans in our region at 58.2. And this is data that's updated regularly at the MDHHS MODA dashboard. And when I get the presentation in PDF form to Louise, all of these links will be able to be usable by you to further investigate or explore. So COVID really was instrumental in kind of exposing longstanding health disparities, not only in Michigan, but in the US and globally. And that really was the trigger for us to engage in a whole nother level of reinvesting in health equity. And we've been doing that since 2020. So we did a formal kind of public facing endorsement of health equity, which is on our website and it's linked there. We developed 2 work groups, the REACH work group and IDEA work group, which Sarah will talk about. And then what we're also here to talk about is the Equity Upstream initiative, which I've been spearheading. And I'll turn it to Sarah to talk about IDEA.
All righty. So our IDEA work group stands for Inclusion, Diversity, Equity, and Accessibility. And it is our internal DEI work group at Mission. So what we focus on is primarily our own employee culture, our policies and procedures, and what makes employees of Mission feel like they belong in working for a place like Mission. It was established in November 2022, and it began with an internal assessment by the Michigan Department of Civil Rights. And there's a variety of internal assessments that are out there. It's a quick Google away. And I believe that also Dr. Marks, our keynote speaker from yesterday, also in his agenda linked a different one if that is something that you choose to pursue at your own agencies. And it's kind of a matter of picking which one feels right for your agency. But the one that we did was Michigan Department of Civil Rights. We had them come in, do this assessment, and then talk to us later about the results. We then formed our strategic plan from those results, and we're coming kind of to the end of it and in a transition period right now. One thing the assessment was really great with was giving us concrete tasks to focus on. One of the areas where it maybe didn't suit our needs completely is addressing some of also what Dr. Marks talked about yesterday in terms of belongingness. And a lot of those feelings of, do I belong here, are intangible and hard to operationalize in a way that makes sense on the form that we were using. So we're currently in our second strategic planning process to learn how to incorporate some of those and feel like progress is being made, not in a way that's, you know, picking policies and just focusing on what's written. We also want to make sure everyone feels welcome when they work for Mission. So some of those successes are we have done a lot of internal policy review, anything from our hiring and recruitment to the language in our strategic planning. We've taken a look at, and that was a huge lift, and I'm really proud of everyone who showed up to that committee and did that work. We also meet regularly. We meet every other month, and we have about 15 to 20 people, which is about half our agency, shows up to those meetings. Some of the barriers are what I mentioned earlier. How do you operationalize culture in a way that makes sense for a strategic plan so you can move forward and, you know, measure it and make sure that you're making the progress that you think you're making? And it's a lot harder for some of those things that are so emotional in nature rather than I looked at X number of policies and made adjustments. The main barrier that we currently face is our group has no people of color in it. And of course, we all bring a lot of diversity that you can't necessarily see, but that is something that is obvious and that we are having start conversations about within our group. Of course, Mission as a whole is also an extremely white agency, and that is part of our discussions as well. But that is one of the barriers our IDEA work group has. And then our other work group, which our lovely Anna is also a part of. So Anna, if you can wave, is our Regional Equity Advisory Committee for Health, and that AKA our REACH group. And this is, unlike IDEA, our external group. And we have a bunch of partners from around our region, some of which are, you know, from provider agencies such as Peer 360, and some are from other agencies that work primarily with people who are from marginalized identities. And all of those external DEI group members bring a different perspective in terms of race, in terms of sexual identity, things like that. And so they are there to provide a non-biased external view on, again, some of our policies and procedures and what needs to be done in the region. Many of the people who serve on our REACH work group have boots on the ground in a way that Mission doesn't, and they're able to generously donate their time to us to be able to share their both lived experience as well as what they're seeing in the communities that they serve. Some of the successes, we hope that everybody who is a participant in our REACH work group feels the same as we do, and it is a pretty special group. I feel that we have a lot of really frank, open discussions, and there's a lot of trust that's been built up so that we can have those discussions in an honest and vulnerable way. They've also, again, generously donated some of their time to take a look at some of our policies, including our land acknowledgement. And it's also volunteer-led, which we get feedback in a way that IDEA can't, because these are people who do not work for our agency and they're able to see things from a different perspective. But that's a little bit of a double-edged sword, because of course, with them being volunteers, we don't want to completely take over their time. So we appreciate whatever they're able to give us. And even though that is, it can be limited in scope because they all live very busy lives, we are grateful to all the time that they do give us.
Great, thank you. So Equity Upstream is another piece of what we've been doing since 2020. Folks are probably familiar with the parable that is the namesake that led us to call it Equity Upstream. The parable about a villager seeing a child floating down the river, rescues the child, but no sooner do they pull the child from the river than another one comes floating down, and then another and another, and the whole village is engaged in rescuing these children from drowning, until someone says, I'm going to go upstream and find out why they're falling into the river in the first place. And that really gets at social determinants of health. It gets at prevention. What kinds of things can be done to avoid people falling into the river, whatever that's a metaphor for. It also gets at implicit bias, because bias is something that's upstream, and it has manifestations downstream in terms of how people are treated, how people are receive services, but it's something that's generated upstream. So it made sense for us to think of it in that way. So what are some of the origins of bias? Because that's one of the things that is upstream and has an impact. If we think about how we evolved as humans, right? There are certain things that we figured out probably pretty quickly were threats. And this was a threat for any human pre-Homo sapiens figure, as well as other four-legged creatures who pretty much knew if we see that thing, that's something to avoid. But then there were also some human specific and clan-specific threats that came about as a result of being in or part of a group versus being outside of that group. And clans evolved, and outsiders were associated with danger because you didn't know if they were going to be competing for resources or attacking you for your shelter or whatever. It's really the origins of the us versus them, kind of us versus other part of our brain. And the part of our brain that's older is the limbic system, and that includes the amygdala, which is where our fight or flight response is, and that's fight or flight as a reflex to specific events. The hippocampus is also part of the limbic system, or the older part of our brain, and it affects memory and emotion, and so it takes these events that have been traumatic or scary or threatening, and it generalizes them into associations, so that if I see someone from that clan over there, if I see that saber-toothed tiger, I'm not just thinking, oh, it attacked us once, it won't attack us again. Our brain generalized these things into associations with danger, threat, risk, and kept those in memory. And then over time, as humans, we developed our prefrontal cortex, which allows us to do what we're doing here today, to think, to talk, to evaluate, to use logic. But what we know is that under duress, logical thought often is bypassed. It just goes straight to that fight or flight and to associations with threat that can affect our behavior and how we react to situations. So there are millions and millions of unconscious associations that our brain develops in modern times. I read as I was preparing for this that our brain is hit with about 11 million bits of data per second. We can only really integrate and sort of consciously work with those and process about 40 of those a second, which is still a lot, but I can't imagine what we do with the 11 million, I'm sorry. So infants very early on start distilling input from around their world into associations. They start to recognize the faces of parents, of caregivers, with safety, with nourishment, and they might associate something that has hurt them with danger. Hopefully not a person, but maybe something that's sharp or something that's needs to be avoided because it could hurt them. They generalize and start to build those associations. Growing up, those associations continue. They start to become more complex through experiences in our families and schools and the community. And it continues as we move into adulthood with social media, of course, now being a huge factor, but also religion, politics, advertising. These all shape our values, what we see as good or bad, what we see as safe or unsafe. These are associations that we evolve over time, not always with conscious thought, but often with kind of unconscious associations that have happened over time. And our brain really uses those associations and generalizations to create shortcuts, to make it easier for us to handle the bombardment of stimuli that we're constantly facing. So the height reference earlier, 15% of American men are over 6 feet tall. What percentage do folks here think that CEOs are over 6 feet tall? 8%, 15%, or 60%? I can't see you, but people can yell it out, so maybe I'll hear you.
We're hearing a lot of 60s, Danny.
Well, you're a smart crowd. 60 is right. And unconscious biases can work positively for someone who is the object of bias. So for every inch of height, it can gain you $789 per year in salary. There's no logic to that, right? There's nothing about my being 6'2" or Sarah's being 5'0" that intrinsically says I have leadership skills that that may or may not be useful in a leadership position. But as a result of biases that exist in our culture, height is something that is a benefit. And that's completely something I think a lot of people would say, oh yeah, well, we didn't hire that person because they were taller than the other candidates who were equally qualified, but it's operational behind the scenes. So there are also, in a more relevant for our work, there are also those implicit and unconscious biases in healthcare. So in 2016, a study was done with a bunch of medical students and medical residents, and it found that many of them endorsed myths like that Black patients have higher pain thresholds than white patients. These are some of the myths. Blacks' nerve endings are less sensitive than whites. Whites have larger brains. Black skin is thicker than whites. These are myths that are rooted in old stereotypes dating back to the days of slavery in the US. And these are doctors, the future doctors of America, who still incorporated some of these myths into their current thinking. Which is scary. We think, we often think, oh, well, there are people who are racist, they're neo-Nazis, they're Klan people, etc. But we don't necessarily think that people who are educated retain some of these old stereotypes that could affect how they view their patients. And the result of these kind of stereotypes is that pain is often dismissed when a person of color, in this case, Black folks, came in for treatment with pain. They were often viewed as drug seeking. And as a result, they were undertreated for their pain. And when someone's undertreated for pain, they're more likely to seek relief elsewhere, often through illicit means. This kind of stereotype is something that we've seen in terms of perceiving certain groups of people as drug seeking, perceiving or dismissing the pain or the suffering of certain patients over others in ways that impacts the care of people in our health system. Again, getting even narrower in focus, we know that there are biases in opioid treatment and in SUD treatment in general. So there's studies that show that there are, I clicked on the link to the to the article. So there are studies that show that folks who are people of color are drug screened more. They're discharged from MAT 3 times more if they have a positive drug screen. They are underdosed with methadone. So there was a study that looked at dosing for methadone, which the minimum rate for it to be therapeutically effective is something like 60 milligrams. And a lot of African Americans were being treated with about 40, which again doesn't give them the relief that is medically necessary for the MAT to be effective. And that gets back to what we started with, right? Why are we seeing these disproportionate impacts in communities of color? And what can we do about it? So as I first started to do the work of educating myself around bias, I developed a presentation which some of you may have seen in the past. I know some of you folks at the Ingham County Health Department have seen, where I tried to pull together all these different ways that systemic inequities exist. And I could do a whole presentation on each one of these: biases in education or in media or in access to jobs, certainly in the criminal justice system, et cetera. These all are out there and are affecting the lives of people who have been historically marginalized, and it continues to this day. A lot of folks sometimes will be dismissive that, oh, we got over that. Slavery ended a long time ago, et cetera. But the residual impacts of slavery, of Jim Crow, of schools that impacted the Native American community, the boarding schools, of the displacement from lands, how we've treated people who are coming from other countries to work in our country. The thing that still kind of hurts my heart is when that bridge got knocked down in Baltimore, and 6 workers who from Mexico and Central America died doing work that was there to support their families back in their home countries. It would have been tragic no matter what, whoever would have died. But I think the fact that those folks are so often misrepresented in the media and in our political system is criminal in my mind. So when we started to move further into the Equity Upstream initiative, the first thing we thought is, okay, I've been doing all this work myself on educating myself and becoming better versed in health disparities and health equity issues. But I know that a lot of folks don't have that and don't have the time for it. So we really wanted to bring a lecture series that was informative. And we brought 4 really amazing speakers, as well as panelists, including Anna, who's in the audience today, when we had our Dr. Warren, the third speaker here, who is from the director of the Center for Indigenous Health at Johns Hopkins University. And and others participated in this series, which we recorded, and those are also available on our website. So when you get this presentation, you'll have the link to that. And from there, we didn't want to just say, okay, here's some information that will kind of illuminate health disparities. We also wanted to give folks an opportunity to do something about it and to translate that knowledge into action. And so we started a pilot with the SUD providers that you see here. And we covered a number of the more diverse counties in our region to start to look at what's going on in their counties, where are the gaps, and what can be done to address those gaps. One of the ways that we sought information is to hear from people with lived experience, the people who we are trying to engage in services, because there's a disproportionate number of people of color who are not engaging in SUD treatment or in recovery. And so we wanted to make sure that we heard from them. And we did 15 focus groups. The providers in the Learning Collaborative ran these focus groups. There were over 100 participants, and the breakdown demographically is here, and it gave us a lot of great information. Well, I shouldn't say great. It gave us a lot of useful information. Unfortunately, it affirmed and reminded us that some of the things we have heard in the literature or read in the literature is happening in our region. And so we, I don't want to, again, take the time to read through these, but, a lot of negative experience, a lot of barriers to care, and a lot of stigma. And again, you'll have the presentation. These are just a few of the comments that came through our focus groups. If you're open about being gay, you have a target on your back in treatment facilities. Went to the ED for abdominal pain and was dismissed as drug seeking, but after 5 hours with no pain meds, they discovered I had an appendicitis and they removed my appendix. There were many things like this. The church being an important part of the Black community, but church people don't want to be around people who use drugs. A major theme that came out of here was stigma. So coming from all of this, as we worked in this learning collaborative, was figuring out, okay, what work do we still have ahead? We know that according to SAMHSA, 92% of people with an SUD don't receive treatment, or didn't in 2021, and it's probably not gotten much better. Even fewer people in communities of color get treatment. And we know that there are multiple reasons for that: the lack of diversity in the workforce, the lack of cultural competency or humility in healthcare professionals, insurance issues, transportation issues, et cetera, but also, as I said earlier, stigma in the community, particularly towards SUD. So there's a lot, as you guys know, because in prevention, this is a big thing that you guys try to address, right? There's a lot of focus on stigma, and there's a lot of literature and programs to deal with stigma. But I'm always struck when I, do research for these kinds of things to see things like the very places they're talking about stigma still using the word abuse. SAMHSA still has abuse in its name, even as it talks about and creates a dictionary where it tries to focus on redoing language. And I wrote to SAMHSA, I wrote to NIDA also about their use of the word abuse. And given everything we know about stigma, why aren't they changing it? I heard back from both of them. And SAMHSA said it takes legislative action, congressional action, to change the name of a federal agency. NIDA said that they were working on it, but this webpage here from NIDA is something I pulled from the website this morning. So even the people who are trying to address stigma still reinforce stigma in some ways. And it's not surprising, right? Abuse is something that is associated generally with negative things, you know, child abuse, sexual abuse. And we know that if someone is referred to as a substance abuser, there's studies like this one that shows that they're perceived as less likely to benefit from treatment. They probably really need more punishment. They're viewed as more threatening, more dangerous, and so on. So these kinds of things, in terms of rethinking our use of language and destigmatizing that, is really critical. So I'm going to show you, oops, sorry, juggling. Okay, so I'm going to show you 3 examples of videos that are attempting to address stigma. And let's see.
And Danny, we have about 15 minutes left.
Okay, thank you.
Words can hurt. Words can heal. So end the stigma. Because when we change the way we think about opioid use disorder and realize it's a medical condition, we can start a real conversation that leads to healing. Learn more at michigan.gov.
Okay, there's one. And what folks who are from the community have said to us, from some of the providers in the Learning Collaborative, is that this is the representation is good. You see a lot of people of color there, but you don't see, the voice is not one that is recognizable or likely to resonate in communities of color. This one was shared as an alternative.
I've always been told I gotta be strong. Thick skin, stiff upper lip, tough as nails. But to be everything for everybody, it wears on you. Black don't crack, they say. But it can. I can. We all can. Y'all, it's okay to not be okay. Reach out to a friend if you see them going through it. No matter who you are, being vulnerable is what makes us whole. Learn how to help.
Okay, that's of course not focused on SUD. It's focused more on asking for help and seeking help. This next one is the one that got the most likes in terms of focus groups looking at messaging to communities of color. Again, it's focused on mental health, but take it away.
Wonder if you know that I want the best for you. That means you're going through a lot. Wonder if you know that the big homie needs help too. You can't just rebound from everything. I know you've been grinding. Let's go. But how long will you fight solo? I wonder if you know that we can get help. I wonder why we waited so long.
Okay. So again, the good thing about that is that it shows and uses a voice that is recognizable in communities of color, and it's more likely to be heard as a result of that. What it doesn't do is focus on SUD, and that's one of the areas that we are really trying to address stigma, because what we know is that stigma is is far more toxic and pervasive in the SUD world. And as a result, it can result in people being more avoidant of getting involved in treatment or even acknowledging to themselves that they have an issue. So the next
And-
steps for us.
10 minutes, Danny. Sorry.
Thank you. Okay, we're winding up. So the next steps for us are, we're going to be working on an anti-stigma media campaign that targets SUD, and particularly in communities of color in our region. The action plans for our Learning Collaborative will be launched. They're being reviewed now, and they'll be launched later this month or in June. We'll be doing staff trainings. We'll continue to provide support, and we will learn as we go. That's what a Learning Collaborative does, because we don't have the answers. We're learning as we go, and we're learning from each other. So takeaways from today that we hope are useful are, first of all, we have to be open to looking at ourselves, both on an individual level and an organizational level. Some of these conversations are uncomfortable, but it's important to not shy away from the discomfort and to be humble and say, you know, I didn't know that, or I didn't understand that, and to learn from people with lived experience. Not everyone can engage in the level of self-teaching that I did, webinars, Zoom stuff, etc., trainings, but staying informed as much as you can with ongoing continuing education like what we're doing here today is really critical. And also important is to ask who's at the table and who's not at the table. It's really important that you have representation from all of the different communities and sub-communities in the areas you serve. And listen to those with lived experience. We talk about that all the time with folks who have an SUD or in recovery, how important that lived experience is. It's also important in terms of understanding different cultures and being better at serving them and working with them. It's also important to remember that diversity is sometimes invisible. So there can be diversity like neurodivergence, there can be different religious faiths and traditions. If we have time, I'll give an example of that, but and how that can play out, and did in my life. But it's important to be open to the diversity that we don't know exists. The benefit of all of this, you know, a lot of times we have people who are skeptics and they say, you know, so this is helping this community, but it doesn't help the majority community, or we're helping putting all these efforts into these communities of color or into the LGBT community, but what about the rest of the population? And this quote from Healthy People 2030 is really speaks to what we believe and the research and the literature shows, which is that as you invest in the full potential of health for well-being for all people in a society, it provides valuable benefits to the entire society. And so that's what our perspective is that by doing this work, we are not just helping the communities that we're targeting, but it raises the boat for everyone living in our state and in our region. All right, I'll wrap it up there and see if there are any questions. Happy to discuss or take any questions.
All right, and I will just go ahead and repeat any of the questions that you do have. So please, we invite you.
I want to hear the story, the neurodivergent story.
We have a request for your story, Danny.
I'm happy to do that. If there aren't any questions, I'll make the story quick. Okay, so years ago, I was up in northern Michigan, and I happened to find myself in a social situation with an owner of a resort, a golf resort up there. And he was very angry with the community. He was getting all kinds of flack about where he was building stuff or what he was doing, and he got very frustrated with the community, and he was drinking. And he blurted out this comment, which was, you know, I'm going to show these people, I'm going to show this community and I know what will really get them. I'm going to sell this place to some New York Jews. Now, he didn't know anything about me. He didn't know that my mother happens to be Jewish. He didn't know that she lived in New York, actually. And I didn't have the relationship with him to confront him on that, as well as the fact that he was under the influence. But that's the kind of thing where people might make assumptions that we're a Christian nation. And so we can make disparaging remarks about people who are non-Christian because we just assume that there's no diversity. And that was one of any number of times where people didn't realize that I have some part of my background that's Jewish, and they made anti-Semitic comments. The other story that I could, first of all, before I do the other one, are there any questions?
I'm not seeing any, Danny.
Okay.
Oh,
So this,
wait.
okay.
Is there an easy way to scale this for, say, a coalition?
Yeah, so Ruth from Prevention Network is asking, is there any way for this information to be scaled down to, say, a coalition level?
Absolutely. I mean, this can happen at any level, from an individual human being saying, I want to look and understand this in terms of my own biases, to looking at a coalition and saying, you know, what's our representation here? Who is the community we're trying to support in the county, in our coalition? What are the ways that who's not at the table? What are we seeing in terms of the data around who is being most impacted and who is not getting the services that they need? If you have a coalition in a county where you go to that MDHHS website and you see that you have a disproportionate number of Native American folks who are dying of overdoses, you know, what can you do as a coalition to reach out to tribal communities, to people like Anna who do this work through Peer 360, and find out, you know, do some networking, do some community building, do some learning around what those gaps are.
Yeah, and if I could just go ahead and add something as well, if you're noticing a gap that we at Mission don't know about, reach out to Sarah Carey or I and say, hey, we'd really appreciate some training, some discussion around this particular topic. If you see a speaker about this or anything, reach out to Sarah Carey and I, and maybe you'll see that speaker again if you were really impressed with them. And one thing that we did with Equity Upstream is run a lot of focus groups. And this is something that's certainly achievable for many coalitions as well, is figure out who's in the community that you're not talking to and learn from those voices and collect that data.
Absolutely. Thanks, Sarah. Any other questions in the last few minutes we have here?
No
All
one's
right.
raising their hand.
Okay, so I'll share this story really quickly. When I was 16, 15 years old, I was taking a bus. My father had moved out of state after my parents' divorce. And my sister and I were taking a bus to go visit him from New Haven to Rochester, New York. And I had on an old hand-me-down Navy coat from a family member who had passed it on to me. And it had the stripes from whatever the rank was. And a guy across the aisle started to talk to me about being in the Navy. And he said he was in the Navy, and I was 15 and I looked older for my age. And so I played along and said, yeah, I'm in the Navy too. This was some silly teenager kind of thing. And then after doing this for a few minutes, he said, you know what we would do when we were out at sea for entertainment? Of course, I didn't know. And his response was, we beat up fags. It was one of the first experiences I had of someone being so hateful and so comfortable with violence towards people who are different in a way that, again, affected me and contributed to years of my working for social justice and being an advisor for a Gay Straight Alliance when I worked at Jackson High School and so on. At the time, I didn't have what it took. I was 15 years old. This guy was an adult. He scared me. I was there with my younger sister. I didn't address it, but it left an impression for the rest of my life. So these kinds of things are things that I'm sure everyone in this room has experienced, especially if you're from one of these communities that has been marginalized. And if you're not, if you're like me, a person from the white community who's benefited from white privilege, it doesn't mean you can't learn from others in your community who have had these experiences, and you can learn about how you can be an ally and be a better ally. And I'm continuously learning from people like Anna, from people like Ricardo, and others in our community. So thank you for being open to having these kinds of conversations. I'm happy to, and I didn't put it on the, I will put it on the PDF of this presentation so that you have our contact information. Always happy to provide more trainings and talk through any questions you have about this kind of work. And I'm grateful for all the work you guys are doing in prevention in our region. So thank you.
All right, and so everybody say bye to Danny. I'm gonna go ahead and disconnect the Zoom.
Take care, everybody. Nice to
Bye.
see you.